Just, I'm sorry, I got logged out. So just want to say thank you for this opportunity. And if you want, if you have any questions, we're available. And Dr. Farid can always get in touch with me if you need anything. But from my side, I think I'm done. So thank you very much for your time.
Thank you, Dr. Thori. Thank you very much. دكتورة زهراء.
أيوه.
You can start. I would like to welcome Dr. Mohammed Al-Rifai for joining us today. And I can see also Dr. Bakir. Welcome to our activity and thank you for joining us. You can start whenever you are ready. Thank you.
Okay. Assalamu alaikum. Good afternoon, everyone. My name is Zahra Idris. I'm R4 from King Faisal Specialist Hospital in Jeddah. Today, my talk will be about mitral valve replacement. A few weeks ago, Dr. Abdelbadi Bogus presented a very thorough presentation about aortic valve replacement, in which he talked about all the types of valves and their hemodynamics. So I'm going to very briefly touch on mechanical prosthesis hemodynamics in the mitral position. The open and resistance to blood flow in the mechanical prosthesis is determined by orifice diameter, size, shape, and weight of the occluder for the prosthesis, the opening angle of the prosthesis, and the orientation of the occluders, whether leaflets or tilt-in disc, in respect to the plane of the mitral annular orifice. And the least resistance to blood flow through the prosthesis in diastole in the mitral position is provided by two things: a large ratio of orifice to total annular area, and a wide opening angle will also improve the effective orifice area. So very briefly, the types of valves. For mechanical valves, I'm only mentioning the bileaflet ones, which are used nowadays. So the St. Jude valve has an opening angle of 85 degrees. The Carbomatics has an opening angle of 78 degrees. The ATS has an opening angle of 85 degrees, and the Onyx has the largest opening angle at 90 degrees. For biologic valves, the porcine valves include the Hancock 1 and 2, Carpentier-Edwards, and the St. Jude BioCore. And pericardial valves, the Carpentier-Edwards pericardial valve, which is made of bovine pericardium. So going right ahead into the mitral valve replacement. So after institution of bypass bicaval cannulation, we expose the mitral valve in different ways. So there are different incisions to achieve mitral exposure. The most commonly used technique is the conventional left atriotomy, and that is what we see in this picture. This one, this incision, which is C. So basically, the way to achieve this type of incision is by dissecting the plane for the Sondergaard groove, which is right here, as we can see in this cross-sectional picture. And after it's dissected, then an incision is performed on the left atrium, close to the interatrial septum. This is one type of incision. This picture here shows us other types. This one is a superior left atrial incision. This one is the Dubose transverse transseptal, where the incision is made on the left, on the right atrium, all the way to the right up the the superior pulmonary vein, and then a transseptal incision is done on the inside in the interatrial septum. This is, as we said, the conventional left atriotomy, and this will be a mini transseptal, and this one is an extended transseptal. Now, the downside for transseptal incisions is they're associated with with occurrence of post-op arrhythmias. So after exposing the mitral valve, the valve will the excision of the valve will start somewhere at about 2 millimeters away from the annulus of the anterior leaflet, around almost 12 o'clock, as we see in this picture. This area is usually the most disease-free area, and then it's continued circumferentially all the way to the anterolateral and posterior medial commissures. Now, something to keep in mind when excising the mitral valve is preservation of the papillary muscles. So the left ventricle normally has a conical shape, and that shape is preserved by the papillary muscles, and it is important to maintain a normal cardiac output. So cutting the papillary muscles will lead to changing the shape into a more globular shape, and this will in turn affect the left ventricular function. So preservation of the posterior leaflet and chordae can also reduce LV perforation and atrioventricular separation during the mitral replacement. Another way to preserve function is preserving the anterior leaflet or by partially excising and the anterior leaflet and bringing it to the posterior leaflet, or furling it to the anterior annulus by running sutures, something like we see in this picture. But of course, there are situations where the leaflets cannot be preserved if they were destroyed, as with infective endocarditis. Moving on to the suturing technique for the valve. For bioprosthetic valves, as we see in this picture, they're inserted preferentially with sutures from the ventricle to the atrium, which are termed as non-everting or subannular sutures. As for the mechanical bileaflet valves, it's the other way around, using everting sutures from the atrium to the ventricle, and then to the Sowen ring. So something to keep in mind are the structures that are at risk during mitral replacement. So we have the circumflex artery somewhere between 6 and 8 o'clock, the coronary sinus somewhere between 4 and 6 o'clock, the non-coronary cusp, or the left coronary cusp, which is somewhere between 10 and 12 o'clock. And finally, the AV node, which can be injured between 1 and 2 o'clock. So concomitant procedures that might be performed along with mitral valve replacement include CABG. So if we're performing a CABG, usually the distal anastomoses should be performed first before replacing the valve to reduce lifting of the heart, which if done after the replacement can lead to AV groove rupture. And also the advantage of doing the distal anastomosis first is the ability to deliver cardioplegia through the grafts. For concomitant aortic valve replacement with mitral valve replacement, usually the aortic valve is excised first, and then when excising the anterior mitral leaflet, care must be taken not to injure the aortic annulus. And then the mitral valve is sutured in place, and the aortic valve after. As for concomitant tricuspid valve replacement, it's usually done after replacing the mitral. All right, so let's take a look at some special considerations when it comes to mitral valve replacement. So the mitral annular calcification. This condition has an incidence of around 2.8% in one study, and it most commonly involves the posterior mitral annulus. However, it can involve the whole annulus, the intervalvular body, fibrous body, and the papillary muscle and the left ventricle. It looks something like this on echo and here on cardiac CT. The issue with the MAC is it carries a high operative risk. It can lead to intractable hemorrhage, AV disruption, and ventricular rupture. The MAC usually affects leaflet coaptation. It can also restrict leaflet motion, and it can also prevent contraction of the atrioventricular annulus. So a grading system has been proposed for the MAC from grade 1 to grade 3, mild, moderate to severe. The grade 1, which is mild, the annular calcification is focal and non-contiguous and limited to less than 180 degrees of the total annular circumference, as we see in this picture. And usually there is no extra annular calcification. Grade 2, which is the type, and in this case, there are dense continuous calcifications that are limited to less than 270 degrees of the annular circumference, which is what we see in these pictures. And finally, the severe form, which is grade 3, they
بابا تحب تلعب هنا؟
So the severe form, there are dense continuous calcifications that extend past the commissures into the anterior annulus, or completely circumferential, so more than 270 degrees. And with this kind, there will definitely be extra annular calcification extending into the posterior or anterior leaflets, or also extending into the papillary muscles or the myocardium. And that's what we see in these pictures. All right, so surgery for the MAC. So surgical technique for replacing a valve with mitral with annular calcification obviously will require extensive debridement of the calcification. This is important to avoid paravalvular leak or valve dehiscence by taking sutures into heavy calcifications. However, the downside for extensive debridement is that we might require annular reconstruction, but the advantage for that is having a strong suture line, and also allows for annular enlargement. And then you proceed with the mitral replacement the usual way after the debridement. Another technique would be intra-atrial insertion technique. This means implanting the valve into the left atrium above the mitral ring and suturing it to the atrial wall. With this technique, we can do minimal calcium debridement. It doesn't need to be as extensive. And here we have a higher implantation of the valve. The downside for this technique would be transfer of ventricular pressure into the atrium, increasing the risk for dehiscence. Another technique for dealing with the MAC is the annulus washer technique. So here, the calcification should be also extensively debrided, and after that, the pledgeted valve sutures are placed around the annulus, as we can see in this picture. And then PTFE felt washer is inserted in between the annulus and the sewing ring for the valve from trigone to trigone. And then the valve and the washer are tied down and then the washer is sutured to the atrial wall continuously, thus providing support to the annulus. Another special consideration is an unclampable ascending aorta. Now, calcifications in the ascending aorta are a common finding in the older population. An extreme form of calcified ascending aorta is known as porcelain aorta, and this usually precludes the possibility of cross-clamping the ascending aorta in the usual fashion, because of high risk of embolization and subsequent mortality with that. So the best approach for this condition is dictated by maintaining cerebral and coronary perfusion while at the same time minimizing the risk of embolization. So here this graph shows how that can be done. So it depends on whether or not there is aortic valve insufficiency. So if there is no aortic valve insufficiency, then we can proceed with the mitral replacement by no cross clamp and doing it on fibrillating heart under hypothermia. However, if there is aortic valve insufficiency, there is a technique of using endo-aortic balloon clamp to basically clamp the aorta, and then performing the surgery also under hypothermic low flow. However, this technique is not reliable, and it doesn't have good results, and it's not used widely. Another technique would be to replace the ascending aorta. Obviously, this is a more radical solution, but it allows for clamping the graft and then proceeding with the mitral valve replacement as usual. Early results for mitral valve replacement. So the risk for elective MVR is somewhere between 5 to 9%. And we have this graph that shows the operative mortality in the different types of MVR. So obviously it's a very low risk when it comes to a first elective MVR, around 3.4%. And then as the surgery becomes more and more urgent or emergent, then the mortality increases all the way up to 39% with a salvage procedure. For redo MVR, the risk is a little increased even on an elective basis, up to 5.7%. However, it goes all the way up to 57.6% for a redo salvage procedure. Late results, so survival after MVR was found to be around 50 to 60% at 10 years. And it's similar in patients who have biologic as well as mechanical mitral valves. The most commonly seen issue in more than 50% of patients post-MVR is chronic AFib, and this increases the risk for thromboembolic strokes and mechanical valve thrombosis, even with optimum anticoagulation. And as we mentioned in the previous graph, redo MVR mortality has decreased significantly in the last 15 years to below 10%. All right, so what are the complications that can be seen following mitral valve replacement, whether early or late? Starting with AV or atrioventricular dissociation, patient prosthesis mismatch, mitral prosthetic paravalvular leak, structural valve degeneration, prosthetic valve endocarditis, anticoagulant hemorrhage, and thromboembolism. So atrioventricular disruption, this is probably the earliest complication that can be seen following MVR. It can be usually intra-op, and it is the most fatal. The incidence is between 0.5% and 14%, and it has a high mortality between 50 and 75%. usually discovered if the patient is unstable after weaning from bypass, or if there is failure to wean from bypass. It can be noted as bleeding from the posterior wall or the presence of a hematoma. Transesophageal echo is not specific to diagnose this condition, but it can distinguish it from other complications such as paravalvular leak or a left atrial dissection. So the types for AV disruption depend on the location of the tear. Type 1 is at the AV groove, and the mechanism for this type of tear would be sutures that are partially within the posterior LV wall, or excessive retraction at the annulus, or of course excessive debridement of the MAC, as we mentioned before, and also lifting the heart after placement of the prosthesis. Type 2, the location is at the base of the papillary muscles, and again the mechanism would be excessive retraction or resection of the posterior papillary muscle. Type 3 is in the posterior left ventricular wall, somewhere between type 1 and type 2. And this occurs if there is a high profile valve with struts that penetrate into the posterior myocardium. So of course, if such a tear is identified, you have to go back on bypass and find the location of the tear, and then it can be repaired by a patch and pleated sutures. Patient prosthesis mismatch. This is more commonly seen in the aortic position with prosthetic aortic valves. However, it has been also reported with mitral valve, mostly reported in the pediatric population, being a reason for redo in that population up to 30%. It can occur with particularly small annulus size, and with a small annulus, there is a need to implant a small prosthetic valve, and that will result in a high transprosthetic gradient. Usually, there is increased risk for this condition with an index effective orifice area that is less than 1.3 to 1.5. When measured by the continuity equation. So previous knowledge of the device's specific index effective orifice area may be helpful to the surgeon to choose a device that will minimize this occurrence. Mitral prosthetic paravalvular leak. The incidence for this complication is 7 to 17%, and in about 1 to 5% of the patients who develop this will develop serious consequences in the form of heart failure, endocarditis, and hemolysis. This complication presents as an incomplete seal between the prosthesis. Incomplete seal between the prosthesis sewn ring and the mitral annulus, with the risk factors being the suturing technique, the size and shape of the prosthesis, presence of annular calcification or infection, usually discovered through the presence of a new onset murmur or symptoms of anemia or heart failure, and the treatment can be surgical or through percutaneous closure more commonly. Structural valve degeneration. This is the most important complication with bioprosthetic valves, and it's seen with porcine valves after about 8 years is when the incidence for it starts to increase to reach about 60% at 15 years. Usually presents as mitral regurgitation from tearing of the leaflets, or as calcific mitral stenosis due to calcification of the valve leaflets, or as both. And in about at least 2/3 of those patients will need reoperations. However, the incidence for degeneration is almost zero for mechanical valves. This table shows the freedom from structural degeneration in all the types of valves in different studies over 5, 10, 15, up to 20 years. As we can see, for most types of valves and in most studies, by 15 years, the freedom from degeneration is less than 50%. Prosthetic valve endocarditis. This happens to be less common in the mitral position than in the aortic position. It is usually, the incidence for it is increased in the initial 6 months after surgery. However, it does have a similar incidence in both mechanical and bioprosthetic valves. And it usually presents with septicemia, septic emboli, abscess formation, or malignant burrowing infections. On echo, there might be a rocking motion of the prosthesis and or vegetations. The organisms are the same, Streptococcus and Staphylococcus, with Staphylococcus being more aggressive disease that almost always requires surgery. Of course, those patients will require post-operatively at least 6 weeks of IV antibiotics. So indications for surgery in prosthetic valve endocarditis include the type of organism. As we said, staph are associated with a more aggressive disease, persistent sepsis, congestive heart failure, systemic infected emboli, perivalvular leak, and large vegetations. Thromboembolism is the most common complication associated with both mechanical and bioprosthetic valves. Of course, as mentioned in the beginning, the better the valve hemodynamics, the lower the probability for thromboembolism. The incidence is about 1.5 to 2% in both types. And the risk factors include a large left atrium, chronic AFib, and the presence of an intraatrial clot. This can be treated with thrombolytic agents and only require surgery in case of an inadequate circulation. Finally, anticoagulant hemorrhage. Now, the INR target for patients with a mechanical mitral valve is between 2.5 and 3.5. And the incidence for anticoagulant hemorrhage has been noted to have decreased markedly in the last, in recent years. And that is due to the fact that newer valves do not require the same intensity of anticoagulation as do older generations of prosthesis. So it is seen less and less nowadays. This brings us to the end of my talk. Thank you.
MashaAllah, very well done, Dr. Zahra. Any questions?
Thank you, Dr. Muhammad Al-Fa'i, for your supervision.
Thank you, Dr. Zahra, for your presentation. I have a question regarding the onyx valve. Do you have any idea, does the target INR change if we put an onyx valve to go with a lower INR level target? Maybe Dr. Muhammad also has an opinion.
So all the recent study was working on the aortic valve. For the mitral valve, like even for the onyx valve in the mitral position, it would go with the same INR target, 2.5 to 3.5.
Okay, so this will be the same for all types of valves, just no change, just for the aortic valve.
Yes, I think so.
Okay, any other question or comment for Dr. Zahra? Okay, thank you very much. So we'll have a 10 minutes break and we'll join at 2:30 for the next lecture.
Assalamu alaikum.
Alaikum assalam wa rahmatullah. Yeah, I just want to welcome back Dr. Mohammed Qudeh again for joining us to this activity. And you can start, Rahman. Thank you.
Okay, so yeah, as you said, first of all, I would like to thank Dr. Qudeh for joining during this lecture. And I just want to notify if you have anything to add, you can just stop me there and add it. You're more than welcome to add it. So inshallah, today I'll talk about the functional mitral regurgitation and the surgery and medical therapy. Okay, so the functional mitral regurgitation, it's not caused by an intrinsic disease of the valve, but by the left ventricular remodeling, dilation, and dysfunction, leading to geometric reconfiguration of the mitroventricular apparatus, including papillary muscle displacement and annular dilatation. A complication of ischemic or dilated cardiomyopathy occurring secondary to LV geometrical distortion by tilting, the mitral valve tilting, apical displacement, annular dilation, posterior leaflet restriction, and regional LV wall dysfunction. So the FMR is associated with a poor quality of life and reduction of long-term survival. Up to 50% of patients and serious problems in cardiomyopathy is the development of functional or secondary mitral regurgitation. Eventually affect almost all heart failure patients as a pre-terminal or terminal event. FMR complicated congestive heart failure predict a poor survival. So it is not just a sign of advanced heart failure, but an independent determinant for heart failure death. There is a strong association between the presence of ischemic FMR severity and heart failure hospitalization. It is a vicious cycle of LV volume overload that causing an LV dilation, leading to a secondary MR, which will cause increased LV volume overload, and LV dilatation, which will cause increasing MR, and this is the vicious cycle where the FMR will be occurring. So MV leaflets become tethered with a failure of anterior-posterior leaflet coaptation, resulting in symmetric or asymmetric regurgitation. Mitral surgery to treat FMR has been undertaken with an acceptably low operative mortality. MR surgery repair or replacement remain controversial. Historically, the surgical approach to the FMR was non-valve sparing MV replacement, was at a time when little was understood of the interdependence of the ventricular function and the annular papillary muscle continuity. So a low ejection fraction who underwent a valve replacement with the removal of subvalvular apparatus had a high mortality rate. So mitral incompetence provided a low pressure relief during the systolic ejection for the filling ventricle, and that removal of this effect was responsible for the preoperative deterioration of the ventricular function. So we'll talk about the Fmr anatomy. So the annulus, leaflet, chorda tendini, and the papillary muscles, as well as the entire left ventricle. These structures form a closure cylinder with the papillary musculature directly aligned beneath the annulus. Most importantly, the maintenance of chordal, annular, and subvalvular continuity is essential for the preservation of the mitral geometric relationships, as well as the ventricular twist mechanics and systolic power. So the MR in heart failure is not primarily related to the valve, but to the ventricular pathology as well. So as the ventricle fail, progressive dilatation of the left ventricle results in outward papillary muscle migration alteration of the closure cylinder, and thus loss of the zone of coaptation. The primary...
Dr. Abdurrahman, if you allow me just to stop you here, I made a comment.
Yes. Yeah, sure.
Assalamu alaikum, good afternoon. Thank you for the invitation. And I hope you will enjoy the presentation and get the benefit of, interacting and asking questions during this presentation. As you know, the mitral valve apparatus is not one structure. It's around actually 5 structures, which need to be all intact and working together anatomically and functionally, so they can be functioning well and keeping the valve competent. So any disturbance of this apparatus, that will lead to disturbance of the mechanism of maintaining the valve functioning normally. And what happened actually in functional mitral regurgitation is the disturbance of this intact mechanism. Mainly, the ventricles become dysfunctional. So due to remodeling effect, either due to papillary muscle displacement or due to infarction, then this mechanism is not intact anymore. So this mechanism are not working anymore in synchrony. Then when you have the incompetence of the valve, and you need to restore this, then you need to work mainly on the ventricle and maybe sometimes on the papillary muscle. You try to correct it at annular level, but this is not the main cause. Is the annular level. It's mainly due to the ventricles and displacement of the papillary muscle. So keeping this in mind, so you will understand there is different mechanism of regurg in the primary mitral valve regurgitation and the secondary or the functional regurgitation. It's not only the mechanism, but the prognosis is completely different. I think this is an important point to just highlight at this stage. And then we'll comment later on about the other aspects of the disease.
Yeah, thank you so much, sir. So the primary lesion in cases of ischemic FMR is a leaflet teethering, which results from the ventricular remodeling associated with an ischemic infarct. The posterolateral and apical displacement of the papillary muscles lead to the apical tinting and restriction of the free margin of the leaflets and poor leaflet coaptation. So the teethering of the secondary chordae can lead to a seagull deformation of the anterior leaflet. Both papillary muscles may be displaced, the posterior papillary muscle usually predominant, so which lead to teethering of the P3 leaflet segment. So in cases of posterior infarction related to the PDA, distribution and mitral regurgite is usually eccentric and posteriorly directed along the P3. And in cases of LAD, infarction lead to more global remodeling involving both papillary muscles and more diffuse leaflet teethering with the large central jets of the mitral regurg. So the annular dilatation and ventricular remodeling combines all MR. It is usually an associated finding as opposed to the primary causal lesion in ischemic mitral regurg.
Yeah, in a related issue here that, posterior MI or inferior MI affecting either the right or the circ, that affect the function of the mitral valve, and it can lead to tethering of the posterior leaflets, and you can get the ischemic mitral regurgitation. It depends on the anatomy. If you have, for example, left PDA and this get occluded, you may get the same effect as if it is a right PDA and get occluded. If the right is a small non-dominant and you have the mainly supply come from the circ, then actually infarction of the circ can give you the same effect as the right. So the anatomy of the right coronary in this situation can affect what the mechanism that's going to cause the ischemic mitral regurgitation.
Yes. Yeah. So the annular dilatation is much less in ischemic mitral regurg than in a degenerative mitral regurg. So Downsizing the mitral ring annuloplasty may best address the leaflet tethering in ischemic MV regurg. FMRs associated with the dilated cardiomyopathies tend to have more symmetric distortion with more annular dilatation than asymmetric in cases of ischemic. As we see here, this is one where we're having a ischemic FMR, which showing asymmetric FMR, and the cardiomyopathy, which will show the symmetric FMR. So, therapy for the FMR, the goal of therapy for the FMR patients is to improve symptoms and quality of life, reducing heart failure hospitalization, and hopefully improve survival. The therapies shown to be most effective are those directed at the underlying LV dysfunction, which is the most importantly guideline-directed medical therapy for heart failure, cardiac resynchronization with or without the defibrillator, if indicated in wide QRS more than 150, should also be considered. Coronary revascularization should be performed as well in ischemic patients, while all patients with a FMR should receive a guideline-directed medical therapy for management of coronary artery disease, LV dysfunction, and heart failure. Unfortunately, the morbidity and mortality remain high. So a recent study showed that among 400 patients treated with the guideline-directed medical therapy, 4-year cardiac mortality occurred in 43 to 45% with the moderate and severe, compared only in 6% in mild MR. So surgery, as per the guidelines, have separated, so the American and the European guideline have separated guideline for the functional or secondary ischemic FMR. These guidelines stated that treating ischemic with CABG or percutaneous method should be primarily undertaken for the FMR patients. All FMR patients should have a guideline-directed medical therapy with consideration of the cardiocirculation if they have QRS greater than 150. If the patient remain symptomatic with severe MR or stage D disease, they may be considered for MV surgery as a 2P indication. So currently, the most common technique to restore valve competence is placing an undersized or restrictive annuloplasty ring to reduce the mitral annulus size and increase the coaptation. The ischemic FMR may persist or recur after restrictive annuloplasty and going to be associated with the ventricular dilation and escalation for heart failure and possible reduction in long-term survival. The surgical mitral annuloplasty improves symptoms in patients with heart failure and has been shown that mitral repair is associated with the low mortality. Several authors have demonstrated 30-day mortality rate as low as 1 to 5%. So the mitral repair in advanced cardiomyopathy demonstrated 3% 30-day mortality and 91 in 1 year survival with a little post-operative recurrence of significant MR. So Akron trial showed 98% 30-day survival rate, 2% repeat operation, and 85% 2-year survival. Significant improvement in quality of life, exercise performance, Niha class, improvement in LV volume and mass and shape was sustained out to 5 years with little recurrence of significant MR. McGay showed no mortality benefit in the FMR after mitral repair. They also noticed that the rate of the recurrent significant to be 30 to 40% in 1 year. Others have shown even higher rate of return regurg up to 80%. So this is this has led to an attempt to identify the surgical predictors for recurrent regurg. So the Achilles heel of the MV repair in FMR is persistent, residual, or recurrent MR, because of the intertrigonal distance is not stable in the FMR patient, with dilatation occurring along not only in the insertion of the posterior leaflet, but also in the anterior portion. So undersizing ring has become the standard for these patients. So the predictors of recurrent regurg, we're having a major predictors such as the left ventricular end-diastolic volume more than 65. The larger of the ventricle, the worse of the outcomes. Coaptation depth of greater than 1 centimeter below the annular plane, angulation of the valve apparatus, all which indicate degree of the LV distortion. So patients with the poor RV function and very high PA pressure should be carefully evaluated and perhaps to be avoided as well. So one of the most predictors, as we said, the left ventricular end-diastolic dimension more than 65, where repair will have poor outcome in patients with preoperative diameter of 65 or less, restrictive mitral annuloplasty with revascularization provided a mortality benefit for ischemic, mitral regurg, and heart failure patients. The other most important predictor, the recurrent FMR, is increased the anterior posterior or septal-lateral annular diameter. When the left ventricular end-diastolic diameter approach 65, that will lead to the MV is having roughly twice the amount of coaptive surface as needed, allowing for LV volume to be changed, and explain why FMR occurs when the diameter is approaching 65 centimeters. So posterior leaflet angle more than 45, undergoing restrictive annuloplasty for the ischemic MR, preoperative echo was shown to accurately predict persistence of the MR and 3-year survival. An anterior leaflet angle greater than 25 to 40 was predictor of the MR recurrence. So the LV function or degree of the MR as determinants of recurrent MR, while other point out the importance of the LV sphericity and tethering depth as predictors. That explains why an undersized valvular repair, decreasing failing and symmetric vascular resistance sorry. So yeah, that will lead to reduction in dynamic FMR by reduction in the mitral orifice area relating to decreasing LV volume and annular distension. The strongest predictor of recurrent FMR following mitral repair was residual large AP diameter. That is a too large ring, and using a flexible ring as opposed to the rigid complete ring was associated with a 5 times higher recurrent mitral regurg rate. So in summary, patients with the predictors of a failure should be considered poor candidate for FMR repair, and alternatives should be encountered. Unfortunately, progression of the ventricular disease may have the worst predictive outcome for these patients. This is not amenable by mitral repair, and must be aware that fundamental FMR is ventricular disease. So, indications for the surgery. So the indications are more cautious than those for primary degenerative MR due to the recognition that surgical outcomes are linked to the underlying remodeling. Secondary FMR can acutely be corrected by surgery. However, it has never clearly been demonstrated that reducing or eliminating the regurg alters the natural history or improves survival. So the response to surgery is different in secondary MR due to ischemic versus non-ischemic cardiomyopathy has also not been established. So a 1-year mortality have after MR surgery for severe ischemic MR, with or without CABG, up to 17%. Therefore, the benefit of MV repair in patient with FMR and heart failure is unclear.
Dr. Abdurrahman, if you allow me to comment here.
Yes. Yeah.
I think just to clarify the issue with especially the ischemic mitral regurg, which we see quite frequently with patients with coronary disease, you know, we know this is a bad disease. It's not only the mitral regurg is not just association, it's an indicative of poor outcome, not because of the regurg, because of the whole disease, coronary with infarcted area or with severe LV dysfunction, and has significant, I'll say significant mitral valve regurg due to ventricular cause. So we know the prognosis is bad. Whatever you do, the outcome is bad. So when we try to fix the mitral regurg, especially when you do the coronary bypass surgery, taking in consideration that may improve the symptoms of the patient. But we know from studies that it wouldn't change the survival, because the disease is already bad. It's the coronary is affected, the heart in a continuous remodeling. It will not stop at the stage when we do the bypass or when we do the mitral valve repair. It's a continuous remodeling. So, and that's the cause of recurrence, high degree of recurrence after you do a competent valve repair, even by TEE, and you check everything looks competent. Then because of continuous remodeling, the tethering and the change in the geometry continue. So patient will come with higher rate of recurrence within the first and second year, may reach to 50%. And actually, when it comes with that, it's already, you know, you cannot help much the patient who already come with severe mitral regurgitation and already has surgery before. She will be reluctant to take him back to surgery to replace the valve, and patient may come with heart failure in a bad condition. So you have to anticipate what is your outcome for this patient before embarking on a specific procedure. Now, it's used to have any type of ring you use to repair the valve will do the job. Rigid, semi-rigid, flexible, C-shape, complete ring. People, they don't have agreement at all about what type of ring and what is it, ring or a band, or what is the best. Lately, there was some studies which showed actually you need to use a rigid ring, not a band, because the intertrigonal area, which was believed is fixed and doesn't dilate, before it was found that it does dilate actually with continuous dilatation of the annulus. It does affect the intertrigonal area. So the suggestion of using complete ring came up. Now, due to also the changes in the anteroposterior diameter of the mitral ring or the mitral annulus, and it becomes almost aspherical, then maintaining the anteroposterior distance, it's important to keep the valve competent in the saddle shape. So it came up the 3D saddle shape rigid ring, which most of the people use nowadays as the ring of choice for ischemic mitral regurgitation. So you maintain the anatomical geometry of the original mitral valve annulus. Now, the problem of undersizing that you may get sometimes to use a small size annulus, you may get element of stenosis later on, or the patient may come later on with mitral stenosis. If you of the remodeling process continue, you may get the regurg. So the problem of repair, always you have to put consideration what is the best choice for the patient and what is the best way that you fix the mitral valve. Now, there are studies came later on that say, well, based on the recurrence of the high rate of recurrence of the mitral valve repair and the need to fix the valve later on due to recurrent admission or persistent heart failure, then the choice becomes what you're going to do with this patient. Are you going to send him, for example, for mitral clip as percutaneous option? But if the valve is stenotic and regurgitate at the same time and the annulus is small, he becomes not a candidate for mitral clip when the valve is small and stenotic, or there is a ring there. So the mitral valve area is already small. And if you put a clip, it becomes stenotic. And then the choices between replacement and repair is extremely important in different patients. So if you anticipate that this valve, high incidence of recurrence after repair, as you mentioned, some of the predictors, then the best way to do it is just replace the valve from the start. And the best way to do it is not actually to maintain the mitral annulus integrity, mitral apparatus integrity by keeping the chordae there and even the leaflets, you don't need to remove them, just insert a valve there. Keep everything, put a valve there, and this may give the patient longer term free from mitral valve regurg. At the same time, it keeps the functioning of the valve because we are not removing any of the chordae or the leaflets, and this may help to maintain the geometry and the function of the valve. So it keeps a little bit of evolving techniques to address this issue because there is no ideal way to manage this bad disease. So currently, what we should practice, if this is expect that the area is not infected, probably ischemic, you do revascularization, and you think there is no severe tethering of the posterior mitral valve leaflets, and you think just putting a rigid 3D ring there, it may get the patient through the preoperative stage and may maintain him better valve function for some times or for a long term, then you can go for repair. If you feel this area is infected and it's not going to improve, there's severe tethering, and you expect the recurrence of mitral valve regurgitation is very high, then I think the best way to do it and we'll go and put valve there. To choose my tissue or mechanical, that depends on different patient categories. So in summary, I think you have to choose case by case what is the best approach for this patient. That's the baseline. This is a bad disease and is not going to affect the survival of these patients by fixing the mitral valve, but it may improve the quality of life and may reduce the hospital readmission with heart failure symptoms.
Yeah. Thank you so much, Dr. Qudeh. So just want to say that in ischemic cardiomyopathy, in ischemic cardiomyopathy patient, MV repair, in addition to a cabbage, did not alter long-term. Hala.
I just have a question for Dr. Qudeh. So what about going from the beginning for mitral clip instead of repairing the valve, just do the cabbage and then do a clip for the MR? So you will have a successful clip.
No, in general, the mitral clip is not better than surgery in general. The mitral clip, the gold standard for the mitral valve is surgery. The mitral clip will be indicated if the patient is not fit for surgery. But if you're going for cabbage and you have severe mitral regurgitation, the best choice is to fix it during surgery because you have better outcome than the mitral clip. Mitral clip has a questionable outcome in different patients, and it has its own complication. and it's only done if the patient is not a surgical candidate. If you go for surgery to fix the coronaries, then the standard of care is to fix the mitral valve at the same time when you have a severe mitral regurgitation. Now, if it is moderate, that's a controversial topic, and it's been different studies. We will have different approaches. Some they will do selective mitral valve repair or replacement in different patients or a case by case. Some they will not address the moderate mitral regurgitation, and they will leave it, knowing prolongation of the surgery and increasing the risk for post-operative complication with no much benefit, including the survival. And there's a chance that this moderate decrease after revascularization. So people have controversial issue about this, and they have been studied, show there is no benefit or there is no difference in patients when they randomize them to go for CABG alone or CABG with mitral valve repair in the setting of moderate ischemic mitral regurgitation.
Yeah, I just want to add one thing to Luai, that I think Dr. Haytham Al-Parhi has sent a good article today to the group where it showed that the mitral clip procedure is not associated with the improvement outcomes compared to the medical therapy alone. So yeah, I think this is answering your question. So
that's the French study. That's the mitral study. That's a French group study. Yes.
Yeah. So moderate FMR, the first published randomized trial from the moderate FMR of a mean MR grade of 2 and LV ejection fraction 43 and moderately dilated left ventricle, the diameter is about 60, showed MR grade, Niha class, and LV remodeling were improved in the repair group. That a trial was not powered for mortality analysis and in hospital and 5-year survival. So the data published in Circulation, the results of the mitral surgery arm of the FMR and ejection fraction of less than 35 from the STITCH trial showed not only a quality of life improvement, but hinted at a survival benefit from the addition of MV repair to the CABG in these high-risk patients. So what do you think, Dr. Qudih, about the...
I think this was challenged. I'm not sure if you came across of this, the CTS-NET study, which was followed for 1 year, then 2 years, then I think now it was studied later on for 5 years. This was the only randomized clinical trial in this subject, which showed there is no difference between patients when they randomize the patients for to go for CABG alone or go for moderate ischemic mitral valve repair. And this was the clinical trial. The other studies or observation study retrospective, which was challenged by the clinical trial done, or is the clinical trial the highest grade of research when you come to a strong evidence that this is going to give you the evidence, this or that. And I don't know if you came across it, if you're going to address this study or not, but this is a well-documented randomized clinical trial that showed no difference between patients who undergo CABG and undergo CABG plus repair of moderate, including the systolic volume and other parameters index, which it showed there is no benefit or clinical benefit of addressing that valve. It's only prolong the surgery that may increase the complication.
Yeah. Thank you so much.
Yeah, so, regarding if you could just kindly go back, Haytham Al-Bar, with you. Yeah, you are commenting here about, give a comments about STITCH trial. STITCH trial, the design or is to answer a different question, not the question of severe MR, and that one you quoted, it was subgroup analysis. The patient
exactly.
MR. Yeah, so as Dr. Dr. Qadeh mentioned clearly. It's in the CTSN trial, and that will be discussed in the details actually in the next lecture by Ahmed Al-Amri, inshallah. So I will not speak about it because Ahmed already prepared good slides about these things. But keep in mind, this is the stage trial. The question in stage trial is not severe MR or moderate MR.
Yeah.
Okay, thank you.
So in cases of severe FMR, there are very few randomized trials regarding for severe regurg. Non-randomized evidence, including the meta-analysis by Visilva, demonstrated no differences in short or long-term mortality between patients treated with the replacement or repair in severe cases. There was no significant difference in the left ventricular systolic volume index. 1-year mortality rate was 14% in the repair group and 17% in the replacement group. So the repair group showed a significantly higher rate of recurrence, moderate to severe MR at 1-year survival. There were no significant differences in the rate of multiple adverse cardiac and cerebrovascular events, functional status, or quality of life at 1 year. LV reverse remodeling was significantly better than in patients who had MV replacement. So in summary, the choice of repair or replacement remained controversial since the MV repair may be associated with the lower short and intermediate term morbidity and mortality, while at the same time associated with a high recurrence rate of moderate to severe regurg, but equal survival in heart failure status. So echo definitions for the MR. So the guidelines on the valvular heart disease proposed definition for the severe FMR as effective regurgitant orifice area more than 0.4, regurgitation volume more than 60, and regurgitation fraction more than 50. So the techniques for mitral surgery, a meticulous attention should be paid to myocardial preservation and cardiopulmonary perfusion. At the time of exposure of the valve, it can be noted that the valve is normally undersizing the mitral is a standard technique approach for the regurgitation repair. These sutures may be put very closely together or even on a diagonal. Some advocate the use of pledgeted sutures or using of an extra row or few pledgeted reinforcement suture posteriorly once the ring is tied in place. So in terms of ring sizing, majority of patients may be well served with the small 26 or 28 millimeter ring. There was concern for post-systolic anterior motion of the anterior leaflet and the mitral stenosis, as Dr. Qadeh mentioned, from such downsizing of the ring. But it resulted there has not resulted in significant clinical skull in the long term. So the type of the ring utilized for the FMR repair is an important technical consideration, as noted that the fibrous portion of the mitral annulus anteriorly between the two mitral trigones dilated proportionally and as much as the posterior muscular annulus. Small, rigid, and complete rings were best for the MR, while the large partial or incomplete ring properly do not result in a durable repair and are not favored technically. There are numerous specific small, rigid, and complete rings with the disproportionate AP diameter dimension reduction. So when coming off the bypass, there should be no mitral regurgitation seen on intraoperative and postoperative TEE. The zone of coaptation should be measured and should be at least 8 to 10, or will have a higher incidence of recurrence. So there are other adjuvant therapies for the repair. As
if you allow me here, Abdurrahman,
Haram.
I think it's important to come from the OR with good repair. If the TE, it showed residual mitral regurgitation or non-durable repair, means there is no good area of coaptation, minimal of 8 millimeter, it should go back and replace the valve. Because this is going to definitely will increase, and patient may become shortly after surgery with severe mitral regurgitation, and at that stage you may not be able to help him. So the extremely important valve replacement is better than non-durable mitral valve repair. I think this the basis of mitral valve surgery should be kept in mind always. You don't come with from the OR already with residual mitral regurgitation, because this is going to increase for sure. You will not going to be decreased.
Yeah.
And you don't have the TE, it doesn't show you a good repair with good coaptation area, no high gradient, no regurgitation. And then the best way to give this patient the benefit of surgery is you should not hesitate and go back and replace the mitral valve, because this will give him a durable, competent valve with better outcome than recurrence, and he will be in bad shape, recurrent admission to the hospital with the persistent heart failure after surgery.
Yeah.
Yes.
Dr. Podeh,
Yes.
would you give him another attempt of repair or just go and replace the valve?
That's all depends of the anatomy. If I know this valve, I was sure this valve is good for repair, and I found when I go back, I found the reason for that regurg, I may go and fix it. But I will not, if the patient from the start is going to have complex mitral valve repair and it's ischemic, I will not go from the start. If it's a simple repair, it's just ring without severe tethering and severe retraction of the posterior mitral valve leaflets, then I'll give him the chance of repair, knowing that I will do a good repair. From the start, I know this is a complex repair, mixed, like a mixed disease of degenerative plus ischemic. The annulus is, the cord, they are thinned and elongated. There is some degenerative changes in the annulus, and I know he needs a complex repair. Usually this is an older age group. The best thing to do for this patient, just put a competent valve there and come out. Don't prolong the surgery unnecessary, especially if you have done 3 or 4 grafts, your surgery is already long. In a patient, usually this patient, they have severe LV dysfunction. And then you'll get a problem of long bypass time and long cross-clamp time. So you have to judge really what is the best for each patient. Otherwise, you get the troubles being ideal for here and there. So you have to tailor your surgery to each case, what is the best in this situation, I think. Yes.
Thank you. So, as I said, there is other adjuvant therapies for the repair, as in cases of dilated FMR MV, there are often deep cleft between the P1, P2, P2, P3, which should be closed, lysis of the secondary cords to both the anterior and posterior leaflet to allow for a longer zone of coaptation. Another one, ring and string by placing a Gore-Tex traction suture in the posterior papillary muscle and bringing it up towards the annular plane, or double annular ring, placing a standard annular ring at the annulus level, and then a second one of Gore-Tex woven around the papillary muscles to recreate the normal cylinder of closure, or the anterior of or the posterior leaflet with the Puvine pericardium to improve the length of the zone of coaptation. But keep it in mind, none of these operations have had long-term follow-up. So a mitral valve replacement, which FMR valves to replace primarily remain controversial. There is an agreement on the technical aspect of the MV replacement for the FMR, which is total valve sparing replacement. partial versus complete coral sparing replacement, the effect on the left ventricular volume and function were much better preserved with the complete versus the sparing. There are numerous techniques for the total valve sparing replacement in the FMR group. So we're having the anterior flip over, where a C-shaped incision is placed in the anterior leaflet and the entire anterior apparatus is moved posteriorly. Then following the valve sizing, a bridget is stitched are placed through the posterior annulus, the edge of the posterior leaflet and flipped anterior leaflet, placing both caudal apparatus and the left leaflet behind the MV prosthesis. There is another one, which is a second, which is achieving total valve sparing, is to remove the center of the anterior leaflet, then rotating the remaining portion of the anterior leaflet to the right and left and placing the prosthetic valve. So, summary, FMR is a ventricular disease, not a valvular disease. Leads to a vicious cycle of LV volume overload and progressive MR, complicated congestive heart failure predicting a poor survival. Mitral surgery to treat the FMR has been undertaken with an acceptably low operative mortality. One must decide on specific patient factor whether or not intervention to correct the FMR is warranted in congestive heart patients, as a clear survival impact has not been shown compared to guideline-directed medical therapy or revascularization therapy alone. If surgery is undertaken, undersizing the repair with a complete rigid ring and valve sparing replacement is recommended. A good mitral repair probably leads to better LV remodeling patients. So patients identified to be at high risk FMR recurrence after annuloplasty should have a mitral valve replacement. More complex mitral operations and percutaneous devices have shown a promising result, but still remain under investigations. And thank you. Any questions? Anything you want to add, Dr. Qudeh?
Well, I think I commented on the important points in your presentation, and you summarize actually what you know, the main approach to this disease. But again, as I told you, the management of these patients, it has to be case by case. But the most important things which you need to keep in mind, that this is a disease of the ventricle, as you mentioned. The prognosis is poor when the patient comes with coronary ischemic mitral regurgitation with severe mitral regurgitation. This is a poor prognosis, and 5 and 10 years mortality is quite high. Choice between mitral valve repair and replacement should be taken in individual cases. Mitral valve replacement is much better than poor non-durable mitral valve repair. So don't be deceived that you want to say, well, I did repair, or I did repair for this patient, but it didn't last few months or few years, and then the patient will suffer the rest of his life. So from the start, choose the best of interest of this patient for the long term, not for the short term, and never hesitate to go back on bypass and fix the problem. So if you know this valve is leaking while the patient in the OR, is going to leak while he's on the floor, and he's going to leak when he's discharged. So fix the problem in the OR, so we give him the advantage of being operated on, and the patient is still in the operating room. Mitral valve replacement is a quick and easy procedure. So it's better to go back on bypass and fix it rather than leave the patient with residual mitral valve regurgitation.
Yeah.
Thank you very much.
Thank you, Dr. Qudeh, for joining us. We all appreciate it. Thank you.
No problem, anytime.
Okay, thank you, Dr. Abdul Rahman. Thank you, Dr. Qudeh. I hope you have time to join us for the next lecture.
I'm sorry, I have a commitment. I have to finish some work outside, and I'm on call. I have to see a few patients referred to me today. I'm sorry, I cannot do that.
All right. Thank you very much for joining us, and we have a quick
Enjoy the rest of your education.
Thank you.
Thank you, sir.
So we'll start at 3:25 with the Journal Club. Thank you. Dr. Ahmed.
Assalamu alaikum. You can hear me?
تفضل.
Can start?
Yes, you can.
Good afternoon, everybody. My name is Ahmed Al-Amri. I'm a cardiac surgery resident in King Fahd Medical City. I have been assigned to present this week journal club about mitral valve repair versus replacement in the case of ischemic mitral regurg. Special thanks to Dr. Haytham Bar for supervising the presentation. If you allow me to start at first with an introduction about the mechanism of ischemic MR, which was reviewed in the previous lecture. And just to understand that ischemic mitral regurgitation is a disease of the left ventricle. So you have the ventricular mitral complex, and multiple factors play a role in the development of ischemic MR. From one side, you have annular dilatation, LV dilatation, papillary muscle widening, tethering of the leaflets. It's like playing a tug of war on the ventricular mitral complex that led at the end of the development of ischemic mitral regurg. This actually resembles the debate between the surgeons in regard of the best choice for the management of ischemic mitral regurg. So the treatment choice, especially the surgical treatment choice of ischemic MR, is still controversial. And in a review of the latest database of the STS, they mentioned that 66% of their surgeons enrolled in the database prefer to do repair for the ischemic MR rather than replacement. If you allow me to have a literature review prior to the trial, and this literature review represents the idea of the best choice of surgical treatment of ischemic MR prior to our trial, and then I will discuss after our trial. So if you have a look at the retrospective meta-analysis from 2001 up to 2013, you will have a common idea or a common finding of a lower perioperative morbidity and mortality with mitral valve repair in comparison to mitral valve replacement. And one study or one meta-analysis of short-term and long-term survival after repair and replacement showed an increased risk of mortality of 35% with replacement in comparison to repair. And other studies also have suggested that there is better long-term correction, in another term, durability, with the replacement in compared to the repair, being repair having more incident of recurrence. Other studies, meta-analysis, had similar finding, and they had also similar survival after the mitral valve replacement and or repair. So there was no significant difference between the two groups in regard of survival and cardiac endpoint. Also another meta-analysis comparing repair and replacement in patients undergoing CABG for ischemic MR had the same idea. So we ended up, the surgeons at that time ended up with an idea, or at the, they have to choose between two options, either better correction, better long-term durability, or higher or lower mortality with the repair. So that's why let us have a deep insight of the CTS-NET trial, which is our talk today, which is talking about the mitral valve repair versus replacement for severe ischemic mitral regurg. And this study was led by Dr. Michael Aker and his group, and sponsored by the CTS-NET. published in New England Journal of Medicine in 2014. The enrollment of this trial started with 3,458 patients. They excluded the majority of the patients due to they did not meet inclusion criteria. They ended up only with 251 patients whom were randomized into two arms of the trial, into one-to-one fashion. The first arm was the mitral valve repair group, including 126 patients. The mitral valve replacement group included 125 patients. Important to note that there was a crossover between the two groups. 11 patients from the repair group was crossed over to the replacement group due to intraoperative difficulty of the repair or failure of the repair intraoperatively. And one patient from the replacement group crossed into the repair group due to surgeon decision. The inclusion criteria for this trial was patient with chronic severe ischemic mitral regurg, whom eligible for surgical repair or replacement, and the presence of coronary artery disease with or without the need for coronary revascularization. They excluded patients with structural mitral valve disease or ruptured pulmonary muscle, and by this they excluded the primary MR and the acute causes of ischemic mitral regurg. They excluded patients with prior mitral valve repair, severe irreversible pulmonary hypertension, the patient who is unable to undergo cardiopulmonary bypass medically. They excluded those patients. They excluded patients with planned concomitant procedure, except CABG, TV repair, or closure of PFO or ASD, or MACE procedure. They excluded the sick patient who's in cardiogenic shock at the time of surgery or requiring long-term intravenous inotropic support at the time of surgery. They also excluded the patient who present with ST elevation MI requiring intervention in the 7 days prior to surgery, the patient with congenital heart disease, evidence of cirrhosis or liver failure, excessive surgical risk, the patient with psychiatric disease or life expectancy less than 2 years, or a pregnant lady. The primary endpoint of this trial was the degree of left ventricular reverse remodeling. As mentioned in the previous lecture, that the ischemic MR mainly a disease of the left ventricle, and one of the most important prognostic factor for any patient with ischemic heart disease is reverse remodeling, as observed by the multiple studies over the years. It was assessed in this study by the means of left ventricular end systolic volume index, which is an echocardiography measure. The secondary endpoint was mortality, MACE, and recurrent mitral regurgitation, quality of life, serious adverse events. The baseline and operative characteristics of the patients enrolled in this trial were equal, and there was no significant difference between the two groups. They were male predominant, about 60% male. The age was between 60 to 80 years old. Most of the patients left ventricular ejection fraction was in the range of 30 to 50%. About 20% of the patients in both groups had a previous CABG. Around 30 to 40% of them had a previous PCI. And concomitant CABG was performed only on 73% of the repair group and 75% of the replacement group. And you end up with 25%, almost 25% of the patient enrolled had no CABG as a concomitant to the mitral valve surgery. The baseline, so they measured the primary endpoint at baseline, and then they assessed it at 12 months. So the baseline left ventricular end systolic volume index was not significant or was equal between the two groups, no significant difference, around 61.1 plus or minus 26 in the repair group, 65.7 plus or minus 27 in the replacement group. The diagnosis of ischemic MR in the study group was made by transthoracic echo by the means of effective regurgitant orifice area of 0.4 or more. If the patient had less than 0.4 centimeter square of regurgitant orifice area, they assess other tools as guided by the guidelines, width of vena contracta, jet area, and so on. After randomization, they found that severe mitral regurg was observed in 96% of the studied population, and the remaining 4% had only moderate mitral regurg. So let's move to the result of this trial, starting with the primary endpoint, which is the reverse remodeling, represented by the systolic volume index. They measured the systolic volume index at 12 months, and after adjustment of the depth, they found that there is no significant difference between the two groups with a p-value of 0.18. There was some improvement in both groups, minus 6.6 ml and 6.8 ml in the repair and replacement group, respectively, had some sort of improvement during the first 12 months. Now we move to the most important point in this trial, which is the recurrence of MR. The proportion of surviving patients with recurrence of moderate to severe mitral regurg at 12 months was significantly higher in the repair group than the replacement group. About 32.6% of the repair group had recurrence of MR, while only 2.3% of the replacement group had a recurrence of MR. This is at 12-month follow-up. And the majority of the patients who had the recurrence of MR were having moderate MR in the repair group. 4.2 only had a severe MR, and all the patients who had recurrence in the replacement group were moderate only. One important observation in this study, which gave an indication of the prognostic value of the reverse remodeling. They assessed the patient in the repair group, and they divided them into the one with recurrence and the one without recurrence. The one with recurrence, they observed that those patients had no reverse remodeling, as compared with those without recurrence who had an excellent reverse remodeling of 47.3 means for the one without recurrence. If
Why
you look at,
Ahmed?
Sorry?
Why it is important? You said this is very important.
Important because of the support that the ischemic MR is disease of left ventricle. If you have a good reverse remodeling, you will have no recurrence.
Yes, that's one point, but what's the other point? Yani clinically, why you brought this point and why they pointed out in the study? Clinically, what the benefits when you said if there is a recurrence and no recurrence, you have good reverse remodeling. What about the replacement? They have reverse remodeling or no reverse remodeling?
No, the replacement had reverse remodeling, but not compared to the one without recurrence in the repair group.
So
The repair group,
if that mean, so what I understand, that mean if you have a good repair, that will lead to better reverse remodeling.
yes,
Which will lead to better outcome, suppose. Because they are not testing here, they testing the volume and the reverse remodeling on the patient in the 2 years.
yes.
Okay.
Thank you. If you have a look at the secondary endpoint at 30 days and at 1 year, there was no significant difference between the two groups in regard of the clinical endpoint. Death was observed in 14.3% in the repair group, while it was observed in 17.6% of the replacement group, with no significant difference. All other clinical endpoint was not significant at 30 days and 1 year, except of hospitalization. Rehospitalization was being shown to be more toward the replacement group at 30 days only, while on follow-up of 1 year, you will see that it was corrected, and there is no significant difference at 1 year in regard of rehospitalization and readmissions. This just to show it in another way. Death, as we said, was not significantly different. There was no significant difference between the two groups, with a p-value of 0.45. Other composite cardiac endpoint also was not significant over the period of follow-up. The quality of life and functional status at 1 year, they assisted by multiple scales and scores, but it has, interestingly, even with that in mind, the repair had more recurrence, but it has no significant difference between the replacement and repair group in terms of quality of life. So the recurrence did not affect, according to this data, did not affect the quality of life of those patients at 1 year. If you have a look at the Niha classification, and at baseline, most of the patient was in the area of the class 3, and after repair or replacement, 6 months, you will find that most of the patients is within the class 1 and class 2, and most of the improvement happened during the first 6 months, as you can see. After that, it's like a plateau, no significant improvement after that. If the patient will improve, usually improve during the first 6 months of surgery. So in the same trial, they published 2 years follow-up, 2-year outcome of surgical treatment of severe ischemic mitral regurg, led by Dr. Goldstein and his group, published in 2015 in New England Journal of Medicine. We'll move directly to the result because the same characteristic and primary endpoint and secondary endpoint. So the result at 2 years in regard of reverse remodeling, there was no significant difference between the two groups in regard of reverse remodeling, and the vast majority of the total improvement in reverse remodeling happened during the first year. After that, there was no significant improvement in the reverse remodeling. 81.8% of the repair group improved during the first 1 year. 96.3% of the replacement group improved in terms of reverse remodeling during the first year. In regard of recurrence of MR, it's continued to increase. At 2 years, the repair group had 58.8% recurrence, while the replacement group had only 3.8% of recurrence, which was statistically significant with a significant p-value. In the secondary endpoint, at 2 years, death was observed in 19% in the repair group and in 23% in the replacement group, which was not significant. Another thing in the clinical endpoint is the failed index mitral valve procedure, which means the failure of repair or replacement, which was observed in 6 patients in the repair group, 0 patients in the replacement group. And those patients who had failed index of repair either had intraoperatively they repaired again or moved to the crossed over to the replacement group. And as you see, the reoperation rate of reoperation was not significant, even though the recurrence is more with the repair. MACE was not significant. The only 2 things that were statistically significant in the follow-up of 2 years were heart failure, tending to be more in repair group, and the rate of readmission for cardiovascular event more with the repair group. So at 2 years, they did cumulative assessment or cumulative risk assessment. So they found that 75 patients of the 111 patients who completed the 2 years follow-up, about 68% of the repair group had either died or had moderate to severe MR or underwent mitral valve reoperation. While if you compare to the replacement group, only 31% or 31 patients of the 107 who completed the 2 years follow-up, 30% of the group had either died or had a recurrence or reoperation, which is, as a cumulative risk, was significant with a significant p-value, as you can see. Again, with the cumulative risk in another way, at 30 days, you can see the repair patient had more recurrence, more reintervention, or reintervention. At 6 months as well, at 12 month and 24-month follow-up. The mortality, the death that was not preceded by recurrence of MR was more in the repair replacement group. But if you look at the death preceded by the recurrent MR or reintervention, was a little more in the repair group than the replacement group. The quality of life, again, assessed at 2 years with no significant difference in terms of physical health, mental health. All other scores showed no significant difference between the 2 groups. So in conclusion of this trial, at 2 years, follow-up of mitral valve repair versus replacement in ischemic MR, there is no significant difference between the 2 groups in regard of left ventricular reverse remodeling or survival. There was higher recurrence in the repair group of moderate to severe regurg. At 1 year, almost 30% versus 2% in the replacement. At 2 years, almost 60% versus 4% in the replacement group. And that was translated into more heart failure in the repair group, more repeated hospitalization in the repair group. So in the next few slides, I will talk about the critiques on the trial. The first one is that the primary endpoint was an echocardiography measure. As we know, the left ventricular remodeling was assessed by the left ventricular volume index, and it's not a clinical outcome such as a survival that you can measure, but it's an echocardiography measure that is can be biased by the operator dependence of the echocardiography, and the measurement can differ from echocardiographer to another. The crossover of patients, the relatively small number of randomized patients, around 251 only, The observation was made only over a short period of time of 2 years. The trial does not evaluate the strategy of revascularization alone. As you can see, as mentioned in the previous lecture, there was a trial, the CTS-NET trial, comparing CABG alone versus CABG plus mitral valve repair for patients with moderate ischemic mitral regurg. And in that trial, they included 301 patients, and they randomized them to CABG alone or CABG plus mitral valve repair. What they found that there was no significant difference in terms of survival between the two groups. The patient with the CABG only, they did have tend to have more recurrence, but it did not translate into more into a readmission or heart failure symptoms. So what they came up with, that repair for moderate MR, ischemic MR, was weak evidence. And this can be also a question that's made in this trial also for severe MR. Do we really need the repair or replacement for severe mitral regurg? There was no previous evidence that have studied this issue. And to have in our trial, 25% of the patients had no concomitant CABG, which decreased the possibility of regional wall motion abnormality improvement. As we know that the MR is disease of ventricle, there is revascularization is the best to improve the LV regional wall abnormality and therefore improve the MR. Another critiques of this trial is that the patient in the repair group were not assessed for the risk of recurrence post-repair. As we know, there was multiple studies that proposed predictor for failure of repair. One of these predictors mentioned here in the schedule, the annular size, leaflet, tinting height, tinting area, the angulation, the left ventricular, the presence of basal aneurysm or dyskinesia. All these factors are a predictor for failure of repair, and patients in our trial group were randomized without assessing the predictor of failure of repair or recurrence of post-repair. Another critiques, which is they didn't mention in.
Sorry, Ahmed. Sorry, interruption, because you mentioned the moderate, the trial for moderate MR when they are going for CABG to add repair or not, and you said there is no survival benefits. And there is another thing very important was shown in that trial, which is the rate of stroke. When you add mitral valve repair, you have more stroke with those patients. You come across that, right?
This patient with who had CABG plus mitral valve repair, yes, they had more neurological symptoms and neurological complications. Yes, and more recurrence with the CABG alone. So at the end, they did not have any good evidence of having concomitant mitral valve repair in addition to CABG for moderate MR.
Yeah, that okay, because in especially in the moderate, because at the expense, in the severe, because it's severe, so you have to intervene either by a repair or replacement, even as per guideline. But for the moderate, you need to assess the patient, you need to see the echo, you need to see the target, yani which one they will benefit more, to add the repair or not to add the repair. If you have good, yani one with moderate MR, but you have good target on the BDA, on the circumflex, you don't have basal dyskinesia, aneurysmal or scar tissue, the ejection fraction, the left ventricle insystolic volume index, left ventricle insystolic dimension, all that you need to keep it in consideration because you added more risk to the patient if you add the mitral. So all that, it came, actually those data came from this trial, and that need to be considered when you decide, because the mitral, adding mitral, ischemic is disease of left ventricle, and you need to carefully evaluate the patient to add that one. Especially, I'm talking now about the moderate one.
Yes.
Just to add that more, so kindly continue the critique.
Thank you for your comment. Another critiques, which is the repair modality or the strategy of repair. It was only mentioned in this CTS-NET trial that they used downsized annuloplasty ring or restrictive annuloplasty, while other clinical trial published or led by Dr. Francesco Nabi, they studied or had a clinical trial of 96 patients. They randomized those patients to either restrictive annuloplasty alone or a restrictive annuloplasty plus papillary muscle approximation. And upon follow-up for those patients, or in the result of this trial, they found much lower rate of recurrence of MR at 2 years than the one in the CTS-NET, 15% in this trial and 60% in the CTS-NET trial. And that the papillary muscle approximation, in addition to restrictive annuloplasty, has better long-term freedom from MR up to 5 years. And the best option observed in this trial was to have a papillary muscle approximation plus mitral valve annuloplasty, restrictive annuloplasty plus cabbage, to have a best results in terms of improvement of LV function and reverse remodeling, MV tenting height and area, and interpapillary muscle distance. So, what is the new?
Kindly, I want to add one thing about also this one, because this one, if you noticed, this trial by Nabi, it is a small number, and he's the one who's did it. Not all the surgeon doing papillary muscles approximation. It's need also, training to know exactly what to do, where to place the suture. So all that, because this is a series by him. Yes. If you look at the literature, you will not find many surgeons doing this. So also keep that in mind.
Yes.
When you are dealing, reading sometimes the evidence is not like you are doing in the real life. If you are trained and you know how to do this exactly, you know the result, you can go forward toward that one.
It's just a question about the strategy of repair. Is it enough to do only undersized annuloplasty ring? This is the question at the beginning. For this
is one of the critique of the CTS-N trial, but the standard among all surgeons is just to do restrictive annuloplasty.
Mm-hmm.
And the idea why he do this, the approximation, and they have a calculation formula for it and how to be done and all that. The idea is to downsize somehow the left ventricle to have the better result, and even the better result in his small trial was the best, as you mentioned, because of he added cabbage, so you have good target to revascularization as well. All that need to keep in mind.
Yes. Okay.
Ahmed.
After, further.
Was it mentioned in the study about the post-op echo? Was there any residual MR after the repair, or
for which patient? For CTS-NET?
Yeah.
Post-op MR, there was no mention about this. Not from
the recurrence. They have recurrence rate.
No, he mean,
no, I mean immediately after the surgery,
yes.
Like post-op TEE. Was it mentioned that there was any residual MR, or just
not
they assume that this is a perfect repair? And
not maybe in the appendix. I didn't saw actually the.
What I know that there was 6 patients had failed repair, and those patients was going back to pump, and they replaced the valve instead of doing repair in the repair group.
Okay, thank you.
Okay, after discussing our trial from 2015 until now, there was multiple studies studying this subject, but one of the most important or the most recent study was a meta-analysis published in 2020 by Dr. Francesco Nabi. And this meta-analysis actually one of the best meta-analysis, quality meta-analysis, because they included 12 studies. 8 of them were high quality randomized control trial, including the CTSNet trial. So at the end, they had around 2,848 patients. And they assess the best treatment options for ischemic MR by comparing the mitral clip with the medical therapy alone, and they compared CABG to CABG plus mitral valve surgery to CABG alone, and mitral valve replacement to mitral valve repair, and restrictive annuloplasty with subvalvular repair approximation versus the restrictive annuloplasty alone. And what they have found that mitral clip had comparable outcome to the medical therapy alone in terms of long-term mortality, hospital mortality, admission, and the composite endpoint, except for reoperation. The mitral clip had a better in regard of better result in regard of reoperation. In regard of the comparison between CABG alone and CABG plus MVR, they included the one with moderate ischemic MR in this meta-analysis. It was comparable in regard of long-term mortality, hospital mortality, reoperation, and readmission, and composite endpoint. Regarding mitral valve replacement versus mitral valve repair, they included our trial today, and they added another retrospective study. And by the end, they found that long-term mortality is equal. Hospital mortality was more. They observed more hospital mortality with the replacement, and reoperation was more with the repair, and readmission more with the repair, as consistent with our trial results. And finally, the composite endpoint was equal between the two groups. The last thing is the restrictive annuloplasty with the approximation versus the restrictive annuloplasty alone. It was comparable in regard of mortality and reoperation, but the subvalvular repair with the approximation showed a better readmission, better result in terms of readmission and composite endpoint. So the effect of
one question back to that table. Okay, when you see this table and they mention the third column, okay,
yes.
column, sorry, the mitral valve replacement versus mitral valve repair, that the repair is better in regards to hospital mortality.
Yes.
So the replacement showing more mortality. What you will understand from this? How yeah, when you read this, what you understand?
For the patient with the mitral valve replacement, they will have, as observed in our trial, the 30 days mortality or readmission was higher in the replacement group, as you can see. So early outcome or short-term outcome is going toward the better for repair, while in the long term it's equal. There is no difference.
Yeah, I get this point, but even you mentioned that 6 patients, they went to the repair, then there were crossover to the replacement group. and then you read that the 30 days mortality is in hospital mortality, the 30 days, of course, it will be better if you do repair.
It was 11 patients.
Yes.
Yes, 11 patients at the beginning, yes.
Yani that, what I understand, in this context, that if the replacement will have higher hospital mortality because the left ventricle is more damaged than in the repair group. This is one view how I will see it as well. Especially you told us that there is some crossover happen because of the failure.
Regarding the crossover, there are 6 patients who failed the repair, so who were crossover, and total of crossover was 11. So some of them, the rest of the patients, 5 patients were crossed over only because of surgeon decision or intraoperative complication rather than failure of repair. But the failure of repair only in 6 patients.
Okay, thank you.
Okay, so let's move to the effect of this trial on the guidelines. As you know, in 2014, there was no statement in the guidelines in regard of preference of repair or replacement over the other. But in the updated 2017 guidelines, they put a statement that it's reasonable to choose chordal sparing MVR over downsized annuloplasty repair if you are going to do surgery on severe ischemic MR as a class 2A level of evidence B, evidenced by our study today, which is the CTSNet study. In 2020, the recent updated guidelines, they downgraded to 2B, class 2B, the same level of evidence, with the same statement that chordal sparing MVR is reasonable to choose over downsized annuloplasty repair. So what is coming in the future? The same CTSNet trial, the one we talked about today, and the one with comparing CABG alone and CABG plus mitral valve repair for moderate MR, they will continue the follow-up up to 10 years, and the next update will be at 2023. Thank you. If you have any question or comment, please. Thank you very much.
I have some comments related to the articles and your interpretation, if that's okay.
Yes, yes, please.
Again, I ask Niha, is there somebody here, a consultant with you on this case, on this journal club?
He left already. He has some commitment and he left.
All right, so I was making points, different points as we go on, and I'm going to ask you to go to some of your slides. مين معانا هو محمد؟ أحمد عفوا. Okay. All right, so the first comment, and by the way, these are يعني the way at the end of your presentation. I wish whenever you go through these articles, reviews, or journal club, is you should tell us 2 or 3 points at the end. Why did you choose? You said this was assigned to you, so that's okay. But you should have a main concern, or whoever shows this should tell us that, well, I was worried about this. It's a topic, it's a hot topic, it's a main concern. We have too many patients with this. Some reason for selecting of this article. So the first question that comes to mind is that why do you think there's? I'm sorry. Back to the point that you should be mentioning. You should mention to us if there's any biases. And you did mention some of these, but you did not specify. This is a point of possible or potential bias that can throw away the results. So that you should really concentrate. Maybe put it with a red light or كده. على فكرة أنا send you a remark. Private remark about your presentation, which will help you when you do the presentation for for the graduation or even at any presentation, conferences, etc. And I encourage all the residents to read how to make your presentation not just average, but even an excellent presentation. Okay, so the biases is one, and then the significance. How would this is significant? How does it affect your decisions for your patients? So maybe you should give us at the end maybe 2 or 3 scenarios saying in this patient, I would do this, or you can ask your colleagues, and then you would choose, not necessarily anybody is wrong or right, but it's an impression from applying the information you get from these articles into those patient scenario. So the first question I have to you, you mentioned something about exclusion. Do not show the slide, do not show it, do not show it. Just tell me what comes to mind when you're talking about exclusion in this in these studies, both studies, by the way.
Exclusion?
So, yeah, you mentioned something about exclusion earlier. What does it revolve around? You remember?
I remember the exclusion criteria, but
okay. What is it? يعني خلينا نشغل مخنا شوية على قولهم بالعربي. What does it revolve around? What is why did they exclude those patients?
They excluded the acute cases. They only include the acute patients.
Okay, yeah. Not necessarily acute as much as there's something wrong with that acuteness. There's something particular. Do you remember the acuteness? What was it about?
The one with acute MI.
Okay, so acute MI reflects not the pathology of the valve itself, but there's something else that we should be worried about. What should be we worried when we operate on somebody with acute MI?
Maybe myocardial protection.
Okay, well, it's at the end, it's high mortality. That's the bottom line. So it's a very significant risk. And if you look at those patients, they are either very high risk from mortality point of view or needing complex repair for the mitral valve. So either of those patients, those who have been excluded, that can select your patients to a very small number compared. They started with 3,000 and they end up with only 200 patients.
Yes.
So it's almost like selecting 10% of their population. So that's why I already have developed enough bias against this article that it does not mean much to me. But okay, that's my own. You should really know where the biases is. Here is one selection bias. Very specific group of patients. They have excluded many of your patients that the one you will be seeing. Okay, risk of surgery or complex. Okay, what about the graft? Show us the. You showed us some graphs before. I know it's kind of كده كأنها ممطوطة شوية بس مو زي اللي هم حاطينها. أيوة هنا. Okay. Okay. So second graft is very interesting graft. Let's try to figure out. Of course يعني أنت حطيتها بهذه الطريقة فالفرق ما هو باين كثير. لكن the difference between at 2 months, the difference is dramatic. It's almost double, or more, even triple. The difference between the red line and the blue line, صح?
Yes, it looks like.
So يعني, but can you tell me what from this graph what inferences can you get? The second graph, the one in the bottom.
Because replacements is carrying more morbidity and mortality as suggested by other studies in the early.
The long term, they are the same.
Yes, at the early.
Okay, but at early stage, at the first 2 months, they also حتى في within the first months, they're almost the same, صح?
Yes.
Something happened at about 2 months, where they separate dramatically between the mechanical, mitral valve replacement and the repair. But the striking thing that after that happens, after that period, يعني within 3 months, look at this the line of the survival of those patients, or the it's called what, composite? Is it composite?
Composite cardiac endpoint.
Endpoint. So, okay. So if you look at the red, it's almost like a flat line. It doesn't change. Yani if you have a patient who survived the first 2 months with no complications, most likely he will be much better than the other one. Why? Because the other one, يعني خلينا ننزل الخط الأحمر هنا على 2 months ننزله على يصير مع الأزرق بالضبط. Okay. So if you just imagine that we can get the red line below down as a whole, مو بس النقطة الأولانية، لا كله ينزل كده مع بعضه، هتتجه السرفايفل أحسن من البلو لاين، لأنه البلو لاين is continuously progressive with time. Continuously progressive with time. صح؟
Yes,
يعني
yes.
لو عدينا مثلا السنة هذه اللي هي 12 شهر، يمكن حتى بعد 2 3 5 سنين you still may have the blue line going up, continue to go up, while the red line is almost flat. This is another observation. The third observation regarding the graft itself, and it's in the next table. You have a table next slide. Next one, please. Okay. You said something here that they are almost equal at a certain level.
Six months.
I'm not gonna repeat that, but I want you to remember what you said. Do you remember what you said?
In regard of the class 1 at 6 months and at 12 months.
Okay, what I remember you said.
I mentioned that the improvement almost happened during the first 6 months.
Yeah, what class were there? Most of the patients were in which class?
In 6 months, most of them are at class 1.
Okay, well, when you mention it, you mentioned that most of the patients are in class 3, but actually you may have misspoken at that time. I wanted to make sure that when you read those or you specify things, you should be critical about what you said. Anyway, there's another graph that you go. We'll go to it in a short while. Let me just see here. The crossover, you mentioned the crossover, and it's very important. What's the significance of crossover? لو في عندنا يعني double blind 2 groups that we are comparing together, what's the significance of crossover?
Well, the number of patients who were crossed over is not 1 or 2.
When you say the number, how much is يعني our critical number?
I don't have a number.
انت ما عندك، بس طيب بلاش، خلينا نقول خلينا نمسكها في البطيخ مثلا. اوكي. معليش. لو مسكنا اي حاجه ثانيه في هذا، لو قلنا لك هذا مثلا بطيخ احمر وهذا بطيخ اصفر، اوكي، وفيها كروس اوفر، انت كم ممكن تقبل يعني في البيعه هذه؟
10%, 5%, 10%.
طيب يعني بالعقل على قولك يعني وصلنا ل 10%. هو في الحقيقه يعني it should be negligible if it's less than 5%, because that's normal variation in biological science. صح؟ Okay. But you can accept even higher numbers. يعني up to 10%, 10 to 15% is reasonable variation that we can accept. Okay?
Okay.
بس بعد ما كده if it goes any higher, then it become a serious issue. So the crossover of 11 out of 126 is about 10%.
Yes.
Is that يعني should that bias you? Should that make it a bias in this patient, in this group, in this study?
No.
Okay, هذه حاجة. بس كمان الأطيب من كده كمان إنه they have moved from the repair group to the replacement group.
Yes.
So if anything, it should make the repair group worse.
Yes.
But we already know that survival is long term is almost the same. So it didn't really different. It didn't affect them between the two. بس في نقطة ذكرها هيثم، بيقول إنه okay, those patients اللي هم انتقلوا من مرحلة لمرحلة, they may have affected the mortality, made it worse for the replacement. Maybe the replacement is even better. بس عشان هدول جاوهم بعد ما جربوا فيهم أول مرة ولا ثاني مرة. انتبهت؟
Yes, I got your point.
اوكي طيب على نفس الكلام هذا على نفس المنوال شايف في عندنا نقطة ثانية اللي هو when do you decide هذا كان في الأخير هذا السؤال بس حطيته دحين قدمت لأنه له علاقة بالكلمتين هذه اللي قلناها when do you consider the decision that it is failed repair?
When you have moderate to severe
which means,
after the repair.
Okay, which means that you have to come off bypass, you have to do TEE, and then you have to go back on bypass.
Yes, which is more risk for the patient.
And I tell you, my personal دحين هنا دخلنا في حاجة it's not science, but you'll find يعني خلينا نقول it's a good judgment from people who have experience, and experience come from bad judgment. لو انت عملت حركه معينه وسويتها مره ومرتين وثلاثه وباد جادجمنت وكان المريض نتيجتها انه he suffered because of your bad judgment, you will learn, you will have the experience, and then later on in your life you'll have a good judgment. طيب هذا سايد تراك على قول قايل ضرب تحت الحزام. بس نرجع نتكلم على هذه الحاله. So would you wait, come off bypass and come off with cross and do a TEE and then find out and then go back? كان معانا الدكتور محمد قديح وقال كلمة يعني يمكن أنا أختلف معاه شوية. أتمنيت لو إنه كان معانا كان قلتها يعني في وشه. أنا ما عندي مشكلة أتناقش مع زملاء وما أزعل منهم، وأرجو إنهم ما يزعلوا مني يعني في لما أتكلم كده. بس يعني to me it sounds like an excessive step, especially in somebody you're operating on for ischemic myocardial, ischemic mitral regurgitation, which is already a bad disease with high mortality and morbidity. So this is my practice, or this was my practice. I would test the valve, repair it. First of all, I would attempt repair in almost all moderate valves regurg. I will attempt repair, and more even if the patient is sick. I feel that's يعني it's better in my hand. وهذا الكلام يرجع للسلكشن اللي تكلمنا عليه في الأول. هو ما شاء الله مضيع لك 90% من المرضى اللي تشوفهم كل يوم وحاطط لك بس very selected patient. لا أنا والله مرضايا أشوف إنه إذا كان عنده more than moderate I would address it. I would not accept يعني that without addressing it. Anyway, so once I address it to the point with the decision to either repair or replace. If I repair it, I will test it right there and then. If the repair is not perfect, I will take it down and replace it. ما حأعمل زي ما
another attempt.
تعمل انت تاخذه على off bypass وتخليه الله خلينا نروح نصلي ركعتين ونشوف ربنا ان شاء الله لا ما عندي هذا الكلام. I would go ahead and immediately replace it, and I would go with the replacement, and I think replacement is in those patients is better than, just like Dr. Qadih قال لكم, replacement is better than half and half repair. طيب في أسئلة تانية برضو والله لها علاقة. خلينا نشوف إيش كتبت هنا كمان. أنت سألت سؤال طبعا another disaster is 25% of the patient did not
do cabbage,
which is bad. It's not عفوا. Okay, the patient then is this patient is going for mitral valve replacement على طول. ما في داعي تضيع وقتك في شيء ثاني. He's already proved to himself to be ischemic, and he is non-operable from the coverage point of view, and you're doing the valve. His life expectancy is definitely not more than 2 years.
Yes.
Do we need interventions for mitral valve? أنت سألت هذا السؤال وأنا جاوبت عليه بطريقة مختلفة، بس أنت لازم تحط السيناريوز هذه. If the patient going for cabbage with mitral regurg mild, تسوي له شيء؟
Cabbage and mitral regurg mild? No.
إيش قلت؟ ما سمعتك.
For patient undergoing cabbage and have mild mitral regurg, I will not do anything.
Okay. So that's exactly what I would do also, and we have evidence for that. طيب severe mitral regurg, would you do anything for the mitral valve?
Severe mitral regurg, yes, if the
على الرغم انه في احد بيقول لك انه والله it doesn't make a difference.
As you said, doctor, but if you have more targets, PDA and circumflex,
لا خلينا patient going for CABG. خلاص انت قررت انك
CABG. Yes, I will do mitral valve.
بالرغم انه ما حد هناك في ناس يقولوا لك ما تمسك الميترال فالف لانه it's the same result، صح؟
Yes, as a moderate, yes, but
لا
we don't have evidence, doctor.
لا تلخبطني، اسمع مني. A patient is going for CABG. He has severe mitral regurgitation. خلاص؟
Yes.
Would you do mitral valve surgery on him?
Yes.
Yes. على الرغم انه في ناس يقولوا لك الحالة هذه ما يحتاج تسويها لانه it make no difference. في ناس يقولوا كده. انت ايش رايك في الناس اللي يقولوا كده؟ تصدقهم ولا ما تصدقهم؟
They saying this because there is no any good evidence from the literature.
طيب وانا هنا ارجع اقول لك الايفيدنس حقهم they select their patient until the point that those group of patients do not match my patients when I see them. وانا اذا عندي قناعه بالشيء اللي انا بسويه patient is going on bypass وكده I know he has a higher risk عن غيره، لكن ما حصدق الناس اللي يقول لك ما تسوي له شيء في severe mitral regurgitation. لا حسوي له when I know it's a higher risk and I know I will do it. خلاص. Why? Because the evidence there في عندنا evidence يبين لك. على فكرة لما أحد يجي يناقشك في الامتحان you should always tell him that this is my evidence, this is what's recommended, this is the guideline. ها؟
Yes.
لا تقول له والله أنا بس عشان ذاك اليوم في العصرية ما شربت شاي. طيب في نقطة ثانية إيش هي؟ Okay. Prediction of repair failure. My judgment, my own bias, is that complex repair is always a prediction of poor repair. But if I have a very good mark, اللي هو we use do you remember the score of mitral valve repair?
The prediction هذه.
لا do you remember the score اللي استعملوه؟
No.
Okay, it's called the Wilkins Score.
Oh, Wilkins, yes, Wilkins Score, but I don't.
And every one of you should know that score very well. If I have clinical evidence, okay, that I can, and I have good experience, and I'm in a good center where I can have very good support, and I have a good cardioplegia system. مثلا زي اللي بنستعمله هذه الأيام اللي هو إيش يسموه؟
دكتور فريد.
ايش؟
Custodial.
Yeah, custodial. If we have that, then I would most likely go with repair. Okay. The only time that I would not attempt repair if they have very good evidence that this repair is يعني مشكلة حيكون في it's a high risk repair or a complex repair. The score is more than 8. The ruptured chordae or the ruptured papillary muscle. And there's thickening and chronic inflammation or a chronic pathology of the valve. Those I will not attempt. خلاص, I would go and replace. لا ضيع وقت المريض ولا أنا save his life على قول ذلك. بس هو هنا حاطط لك طبعا أشياء كثيرة which good to know. بس أنا I think you should be very conservative with it. You should decide from the beginning. Yes, I can repair or no, I can't repair. طيب ذكر الدكتور هيثم قال على CVA. Okay, I do very good mitral valve surgery and I have very low risk of CVA. From air embolism, for a pump machine, for air filters, for plastic particles, for all this, I have reasonable number of maybe 1 to 2%, which is lower than the STS score for CVA. So that does not prevent me from adding a procedure, mitral valve procedure to the patient. سامعني يا هيثم?
Yes.
If you think that in your hand there is a higher risk, I agree with you, but to a limit. If you have severe, I would definitely do it. I would take the risk. I would tell the patient this is the risk. I'm willing to take the risk, and I'll do it. But if it's moderate, then it becomes the question: should I not? That's a different issue.
My comment was Farid, for the severe, I will go for it, either repair or replacement. However, with chordal preservation, replacement, and I think myself, if I start doing, I will go most likely, and currently with the replacement immediately. For the moderate, that's the one I will think about, to be honest. Or I will have one senior consultant with me. I will discuss with him the case.
Or even ask him to help you. But after 10 years, once you have very good experience with mitral valve repair, and you've done 1,000 cases of mitral valve repair in different kind of pathologies, degenerative and the rheumatic and things like this. Now you have the experience and you decided that, yes, I can do it. I would support you for that. Okay, well, I think those are the points that I want to mention. Again, remind you, if you put those 3 scenarios we talked about, CABG with mild, CABG with moderate, CABG with severe, and what to do at the end of your presentation, it will answer the 3 questions that you should look for. The first one is what biases there is in the article, what's significant, how does it affect your decision, and those are the examples of my decisions. يعني حاجة كده تحلي الموضوع على قولك. Again, quite a bit of my talk is not scientific, but it's based on quite a bit of experience. بالتوفيق إن شاء الله.
Thank you for commenting.
واليوم كان أجمل يوم لأنه فعلا it's very good to see Dr. Haytham and Dr. Amri. عفوا أحمد مين؟
أحمد العمري.
Al-Amri and Dr. Luay have collaborated very well in producing the first journal club for the year 2021. يلا إن شاء الله كل مرة نشوفكم كده.
I have also one suggestion for the next one. Luay, kindly, what will be the topic for the next one?
Next week, you mean?
Next week, yes.
Next week topic?
For journal club, I mean.
I think the Everest trial, but I'm not quite 100% sure.
What about if we make it between 2, okay, not 1? We can discuss it. This is between me and you, Luay, after the session, but I'm just giving an idea. So like Everest or FAME trials, head-to-head. I mean the topics. So let's say, and I will do mitral clip for this specific patient, in one scenario. No, I will do mitral, no, I will do medical, and I will defend myself. So I will do this because 1, 2, 3. We'll make it like a debate one time and see how that will go. What do you think, Luay?
Sure, it's a good idea. We can arrange for like this one time and assess afterward.
Yeah, and between 2 and debate, and at the end we'll see what as a topic on a specific case, and everyone will bring his what they call it evidence and weapon, and he want to win this debate. How he will convince us to go for this one or that one.
In Sultan عنكم, maybe he can bring a cake or something.
If all residents,
especially for the controversial topics, we can do that.
If all of you like it, or also Murtada, we kindly need your input for specific this one, and we can start something like that.
I want to give one input for this previous discussion. I read this article a long time ago, maybe 3 years ago. But if I remember correctly, the type of neurological dysfunction that happens with mitral repair plus CABG is the type 1, which is the milder type, not the major neurological dysfunction. So I just wanted to point that out.
Good. So what's about the other idea? How you think the journal club supposed to be? You can do like...
Yeah, I like your idea. It will be entertaining, like watching a football match.
No, like in the court, So everyone, I think this is right because 1, 2, 3.
Yeah, and then the other group, then the rest of the group can join in this team or that team, and it will be a nice debate.
Okay, I will discuss with Luai outside this. If any resident, any of the doctors here also have another idea or how to modify it, please yani, share.
But when we debate about something, I think it's better to debate on a specific scenario, so we can, yeah.
We can.
Yeah, so we can argue about the details.
So we can set this weekend, me, you, Luai, we'll see.
يلا بالتوفيق إن شاء الله. نشوفكم على خير.
Inshallah.
Thank you, Ahmed. Thank you all for the nice discussion, and Dr. Farid also.
Thank you very much for attending, and see you next week, inshallah.
Also, I will call you later. Thank you.
Sure.